I'm Dr. Tiffany Lamonde from Apex Wellness Providers, and this is
Dr. Stephanie Hope.
And today we are doing part 4 of a series where we're going to go through a full history, physical, and education of a pelvic health exam of me by Dr. Hope.
Yes. So what I'm going to do is ask Dr. Lamonde the typical questions that I would during an intake, which is the history is kind of quite exhaustive depending on how symptomatic you are and your surgical history and all of that.
Okay.
So we'll go through that and I'll ask the questions. I'm not going to type the stuff into here, but I'll ask the questions.
Okay.
And then so you can get an idea of the things that we talk about. So what brings you to pelvic floor physical therapy?
So there's a couple of different things. After I had I only have one biological child. It was a vaginal delivery, and immediately after I had pretty significant stress incontinence. I went to my OBGYN who wanted to give me medication, and I said, I don't have urgency, this is clearly mechanical, can you refer me to pelvic health? He did not have those resources, which was surprising. And so as a result, this is a secret, nobody knows this, I actually went on to get my own education and certification in this arena. To be clear, I have a minimal amount of education, but at the time it was sufficient for me to dramatically improve my symptoms. And it's not really relevant what the education was. Then, fast forward, basically after I had my son, I developed heavy bleeding that got progressively worse over the years, to the point where I had multiple episodes of hemorrhaging that almost required a hospitalization. And then about a year and a half ago, well, probably starting about 4 years ago, that got notably worse. The incontinence really was unchanged. I would only have a little bit of leakage occasionally, especially if like my bladder was really full and I was doing something high stress, like a trampoline or like high speed running on a trail, but not always. It didn't always happen, and it was very annoying when it did, but it was, I didn't have to wear like a pad or a device or anything like that. And it was definitely correlated to right before I menstruated. So apparently, this is correlating, if you want to, I'll link in above sort of the series about my hysterectomy, but essentially what happened is, it turns out I had a very large uterus, about the size of a football. I had multiple very large orange or apple-sized fibroids, and then too many to count small fibroids. Fortunately, I didn't have pain. Apparently, I did have some endometriosis as well. I did not have pain associated with that. I really didn't have pain at all, but I did develop very, very, very heavy bleeding. So much so that even despite what I would consider to be a quite healthy diet, I was developing mild anemia, and after my menstrual cycle, pretty significant fatigue. I am naturally an energetic person like this, so it was kind of an unusual feeling for me. I had been told several years prior that I should get a hysterectomy. I was not in a mental place to do that. And then I went for a follow-up with a surgeon that I really love and trust, and I'd love to mention her name, but she is no longer practicing. She's like retired. Super sad about that. I know, it's a bummer. That said, just to kind of give you a background of like how that hysterectomy thing went and sort of how I responded afterwards. So at the time we were talking about perhaps doing an ablation until she did my internal exam. And then she went, okay, this conversation just completely changed. We're gonna get you an ultrasound today. I think she was probably concerned that I had a tumor. And then she did something really cool, and I've mentioned this in my other videos. We were talking about all the different options, vaginal hysterectomy versus abdominal hysterectomy, so on and so forth. And I asked her, which I think is a really great question to ask your medical providers, is what would you do if it was your body? Or what would you do if it was your sister or your mother?
Or your mother, yeah.
Exactly. What would you recommend? And she did the coolest thing. She said, no one ever asked me that question. She said, let me think about it. And she actually stopped and she kind of looked down, and for about 30 or 60 seconds, she was very quiet. And she really thought about my question. And she said, we should do an abdominal. I want to take it out in one piece because I want to be able to send it to pathology. And if there is something abnormal, I don't want to chop it up into pieces inside of your body so a rogue cell does not go somewhere it shouldn't go. And I was like, then let's do that. So a couple of other symptoms I had before my hysterectomy that is potentially relevant, especially now, and this is part of why I'm seeing you, is I had discomfort when, so house stool churning is when your poop kind of moves its way through your intestines, and so when I would have house stool churning in my lower, probably where my large intestines transitions to my rectum, I would have some pain. Not every time. It was not long lasting. It would be anywhere from a few seconds to maybe 30 seconds. It also turns out I had apparently multiple ovarian cyst ruptures over the years. Again, I'm fortunate in that, yes, during a rupture, it was really uncomfortable, and I would have symptoms that felt like they were gonna maybe go up and down. And they would only last about 20 to 40 minutes, and then they would resolve, and I did not have like lingering pain where a lot of ladies do. Just to be clear, if that's you. Yeah, so most people are sore for a couple of days. That was not my experience. So after my hysterectomy, all of these symptoms went away initially. The discomfort with the fecal matter went away. The incontinence improved. That little bit that I had improved, especially around my menstrual cycle because I didn't have one anymore. Also to back up, I also have a bladder prolapse that's been diagnosed by my OBGYN. I do not believe that that has improved at all. I think that that might be present. I'm super curious what you think about that. And then my, obviously the anemia went away. The fatigue associated with that went away. I did actually have about a 10-pound weight gain after my hysterectomy, which is sort of odd because I retained my ovaries, and that has just kind of stuck around. Could also be a perimenopausal symptom, yay. But it was pretty quick afterwards, and then kind of just stayed there. No more, no less, no change, 8 or 10 pounds or so. From a vanity perspective, it bothers me a little bit, but in reality, it's not a super big deal. And let's see, do I have any other symptoms currently? Oh, so about a year after my hysterectomy, that colon symptom returned, and that was a bummer because I really thought it was related to maybe the volume of my uterus pushing on my colon, and so as it would come around, there was some discomfort. Apparently, that's not why. So,
and we kind of discussed this kind of obviously off camera, but maybe there's like a little bit of endometrial tissue that's
could be
made its way there,
could be,
or some scar tissue, or something's kind of pulling on that area. Or, you know, once you have your colonoscopy, they could say everything's totally normal.
And I have a colonoscopy coming up, my first one in March, which you guys will all be.
Stay tuned for that episode.
Yay. The other symptom that I have is, well, prior to my hysterectomy, again, I assumed it was because my uterus was so large and heavy. When I would urinate and my bladder was full, sometimes I actually felt like I couldn't go, or it would go straight forward, like it wasn't going down. Also, after my hysterectomy, all of that improved, but very recently, for the first time ever, I now feel like my urination stream is weaker. It takes longer for me to void, and I do feel like I might have some retention at the end. And so one other additional symptom is fairly common. I was expecting after my hysterectomy, I had some back pain. It was not severe, it was very central, didn't radiate. And then as I became stronger in my abdomen, which I still feel like my muscular endurance in my abdomen is decreased, but I feel like my overall strength is fairly similar. But I do still have a little bit of intermittent back pain that has persisted. It's not bad, it doesn't stop me from doing anything, but mostly when I notice it is standing and laying on my stomach. I used to be able to lay on my stomach very comfortably. Now
it's extension.
Yeah, it feels like like compression, and then if it goes on long enough, like if I have to queue in a line at say Disney World, it feels like I can't physically bend over. Like it becomes so tight and so stiff. But that does feel like what I want to do.
Is flex.
Yeah, I want to do this, and it again is not radiating. It's not numb or tingling or going down my legs, but it's
Just central.
just central back pain, and it doesn't favor one side or the other. It's quite similar on both sides. And the last weird symptom, so if you've watched my other video, I did have a nerve injury. The nerve was not cut, but it was a traction injury from the retractors. It's called your ilioinguinal nerve. It's the nerve that kind of innervates your skin right here. That was by far the most painful part of my recovery. Didn't last that long, it was about a week and a half, and it did recover because I knew how to do fascial treatments, and because that can turn into something really nasty. However, I have this weird symptom now that I cannot figure this out. So I'm super curious if there's any relation whatsoever. So she'll know what I'm talking about. My lateral femoral cutaneous nerve, but not the whole thing, a very small patch. It is right here. Occasionally will burn, and it is totally unprovocable. I cannot find a position. I cannot find any sort of consistency of time of month, movement patterns.
Clothes you're wearing.
Nothing. At first I thought it was a pair of pants that had like a piece that was irritating.
Rubbing.
It is not, and it is not there all the time. And when it comes, it will come in a series. I will feel it maybe every 3 to 5 minutes over a period of time, and then it just goes away. I know. And if we need to, we can cut this out because I don't know what the heck that is.
I'll have to noodle on that one.
Yeah, I even had one of the other therapists, I was like, hey, do a full like hip exam on me. See, nothing. I can't reproduce it. And I will say, when that happens, because it's definitely nervy, it's like it'll make me gasp, and it makes me want to scratch it. Makes me want to like rub it and scratch it.
And like no matter how you move your back, you can't make it go away.
It's so brief when it happens.
Okay.
It's not even really time to do anything about it.
Okay.
And I can't bring it on by getting in any position, whether low back, hip, knee, nothing.
Have you fascial blasted that half?
Definitely, I do a fascial treatment on my whole body once a week, usually on Fridays. Fascia Fridays.
And that hasn't helped that?
Like
decrease the frequency?
I would say no. If anything, when it happens now, it lasts longer. I know, it's a weird one. Of course.
Yeah.
As physical therapists, we're going to have like something super obscure.
Well, we'll see if we can figure that one out.
I don't think there's anything else in the history of that part of it.
Well, let me just say that patients don't ever give me this detailed of a history.
Note to you, give detailed information.
All I had to say was what brings you to pelvic therapy. Let me go see if...
And we can redo this if you want, like more.
No, it's totally fine. Let me see if there's anything that you didn't touch on. Okay, so if we're talking about your habits, how often do you go to the bathroom during the day to pee? If you had unlimited access to the toilet and you weren't seeing patients all day.
Okay, barring high variability in my water intake, I would say 5.
Okay.
That's a guess.
Okay.
That seems approximately correct.
So you can comfortably, if you were to sit down and be drinking your normal amounts of water and all that, would you be able to comfortably sit through a movie?
Yes.
Okay. Do you get up at night to pee?
Sometimes.
Okay.
Especially if I drink more, especially late in the evening. Like if I have not had enough water during the day and I feel thirsty and I have a lot of water in the evening, I will usually get up once during the night.
Okay, totally normal. Do you feel like most of the time you completely void your bladder?
Up until very recently, and now what will happen is I just have to wait a moment and then it will complete.
Okay.
I don't push or anything, but I just have to kind of sit there and wait, 10 seconds, and then it seems like it will empty, I think.
Okay. And then tell me how much water you drink during the day.
Well, because we just had our water challenge, I try to drink 2 liters of water a day.
Okay. Are you drinking anything else?
I would include the other things that I do drink with that. So I do drink a fair amount of herbal tea. Sometimes I have more than 2 liters, sometimes I have a little bit less, but in general it's somewhere in that neighborhood, probably 60 to 70 ounces a day. And sometimes I have decaffeinated coffee. I don't drink anything with caffeine at all because I'm like this all the time. And
juice, milk, alcohol?
I very rarely drink alcohol. Maybe 2 to 3 drinks a month. Juice, I couldn't tell you the last time I had juice. Seltzer water, plain seltzer water,
Mhm.
I like that. Not artificial sweeteners. I don't like the taste of artificial sweeteners, plus there's other health reasons why I choose
Sure.
not to drink them. Soups, I eat a fair amount of soup,
Okay.
fruits, things like that.
Milk.
If I do, it's generally soy milk.
Okay.
I don't drink it by the glass either. I will have it in things.
How about bowel movements? How are those?
I have good bowel movements.
Okay.
I have at least one a day,
Mm-hmm.
usually in the morning. Well formed. I don't have to push hard. I don't have pain. And sometimes I have another one,
Okay.
especially if I am taking probiotics. I will sometimes have a second.
Okay. Great. Any difficulty or pain with sex?
Before I had my hysterectomy, sometimes, oh, this is going to be personal, with
You can cut this out if you want.
yeah, with deep penetration,
Mhm.
specifically, I think it was actually my cervix was tender
This is before your surgery.
before my surgery.
Mhm.
I no longer have a cervix,
Mhm.
so I don't, and maybe it was just hitting my uterus or fibroid.
Mhm.
Nathan will die if he ever watches this.
You could just like blur this part out and be like, boop, 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 behind the scenes. For respect for Nathan Lamonde.
Or maybe he'll be flattered.
Yeah, true. He's like deep penetration. Yeah.
But in general, no.
Okay.
No.
Okay. And so you don't remember, like, there hasn't been a time recently where you've had discomfort or pain?
No, there can be irritation afterwards,
Yes.
mildly,
Okay.
but it's pretty doable and it resolves fairly quickly.
Okay. Good. All right. So
This is the part that's most uncomfortable.
some people would rather talk about their sex life than their bowel habits. It's interesting.
Oh, I can talk about poop. That doesn't bother me.
Yeah, me too. I'll talk about all of it. So we already kind of talked about your obstetric history. Did you have any complications like with the birth?
The only thing that I would say is it was very long,
Mm-hmm.
and I pushed for a very long time.
Okay.
And then ultimately ended up with an episiotomy.
Mm-hmm.
I had a very easy recovery afterwards. I think I did really well.
She tried to run a few days postpartum. I don't recommend that either. Don't do that. And then when was your hysterectomy?
It was August, about a year and a half ago.
Okay. And then when was your last gynecological exam or like follow-up? Then.
Yeah. She told me I should go back every 3 to 5 years for a vaginal inspection,
Mm-hmm.
but I don't need to obviously have a pap smear anymore because I no longer have a cervix.
Right. Are you using any other kind of medications or supplements?
I do take supplements. I don't take any medications. So as far as supplements, I basically alternate. I use a Super Green as a supplement, not as a replacement for good nutrition.
Mm-hmm.
And then I sort of alternate that with a group of supplements. And okay, here we go. Ready? Probiotic, vitamin D, vitamin C, magnesium and zinc, which I should take in the evening, but I can't remember, so I take it in the morning. A multivitamin,
Mm-hmm.
B
I
complex.
was gonna say B complex. Yep.
I think that's it.
Okay. Are there any other health conditions that you see a doctor for, or you use any kind of treatment for?
As far as like ever,
Current ones that you're doing.
current, I don't have anything I'm currently being treated for.
Okay.
I do have a history of a benign arrhythmia in my heart.
Mm-hmm.
I've had a full stress test echocardiogram workup. It does not require treatment as long as I can live with it. And generally speaking, when it kicks up, if I take magnesium, it goes away.
Cool.
And I've had an ACL reconstruction and a tonsillectomy.
Okay. Great. And then I would normally, I mean, Dr. Lamonde already gave me this, but you already gave me like stuff with your back and your hip.
Mm-hmm.
So I do ask about that too, but she already gave it to me because she's got a PT mind.
I just gave you everything.
You gave me everything. So I'll ask about if they've also had any other kind of abdominal surgery. So that's like, I talk to people about, you know, they had their gallbladder out like 15 years ago and all that
or
stuff.
their appendix or
Their appendix like I had last year. And then I talk about their back pain. A lot of pelvic floor dysfunction patients have back pain.
right.
So we talk about their back pain, the quality of their back pain, what makes it worse, what makes it better, things that we would normally ask in an orthopedic
Exam.
PT exam. And then I do the same thing with hip
Mm-hmm.
if we've got the time.
Oh yeah. There is a new symptom. Very recently, I have developed right deep butt pain when I unload my leg, and it is not consistent. It was pretty bad yesterday morning, went away after a little while. That has happened maybe 3 or 4 times in the last couple of weeks. Feels like it might be SI joint. Can't say for sure.
Okay.
It's not radiating down my leg, but it is deep inside my butt, and it's when I pick up my right leg, like unload my leg.
You feel it when you're working out?
No.
Okay.
Well, the other day, so I'm going on a kind of training up for a 20-mile hike with my oldest son and a friend, and we did a 10.5-mile hike, and by the end, it didn't hurt, but it was tight.
Okay.
But not painful.
Okay. So that just triggers me that if we do have the time, that I go and do a lumbar exam on the patient, and then also a hip exam. Oftentimes we don't have the time in this initial appointment, but I put it on the back burner. So for Dr. Lamonde, that would be like, okay, let's look at your back and your hip in a subsequent visit, because it's all together and it all works together. Let's see if there's anything else that we've missed. I don't think so. So what I would do now is I would give you the education that we talked about in the previous video, talk to you about anatomy and physiology. I would put in your own kind of symptoms.
So let's link that video here if you're interested in some of the details of that.
I would talk about your symptoms and how that kind of works with the anatomy and why I think that's happening for you based on your history, but then with the caveat of course, when we do the exam, we can find other things. So it might not be what I think it is, but this is initially what's kind of popping out at me. And then I talk about the exam. So I'll give you the spiel now of what I do in the beginning. Usually I do this with patients when they're, I do it before so we can gain consent. So, or people can deny consent, that's fine too. Totally fine. And we just switch it up and we do something else.
I'm probably going to give consent.
I think she will. So the pelvic exam is unlike any exam that you've ever had. And I say that confidently to most patients, unless they've been to another pelvic floor therapist that I know. Because I've heard some crazy stories out there with pelvic floor therapists and their exams. But so it's not just the pelvic exam. It's also, I'm looking at your breathing. So I'm looking at your breathing pattern. I'm looking at how your ribs are moving, how your chest is moving, how your belly's moving, all of that. I feel around on your abdominal wall to see if there's any restrictions, pain, referral pain down into your pelvis, back to your back, down into your hips, all of that stuff. Sometimes I do a little bit of coaching right there, so I'll teach you different things of how to change your breathing pattern, and we'll kind of talk about that during the exam. And then if you're comfortable, we do an internal pelvic exam. So what that entails is that you're laying on the table, you're completely draped the whole time, so you're not just kind of waving everything in the wind there. It's very comfortable compared to what women are usually used to.
I hope nothing would wave anyway.
No, not waving. But we don't want anything like exposed to the elements beyond your comfort level. So I don't use stirrups. I'm not putting you in stirrups. You're on the table and your legs are supported comfortably the whole time. So I talk to you the entire time. I'm telling you what I'm doing, what I'm feeling, what I'm finding, and then I'm getting you to help me. Are you gonna sneeze?
I thought it was, no.
Okay.
It's making my eye water though.
I can see your eyes watering. She's getting scared.
Is this a sympathetic nervous system
Yeah.
response?
She's like tightening her jacket up, and she's slowly like.
It's all subconscious.
Yeah, so then I also, this is in the other video, but we can talk about this here again real quick. So I show them this pictures. So we'll insert the little exam picture here. So I explain that, we're using one finger to assess the musculature inside your pelvis, and this is why we do the internal exam, so that we can access the musculature here. Otherwise, if we try to do it externally, we can still get some information on your pelvic floor, but it's not perfect. It's not all the info that we could get by doing an internal exam. So we feel around on the musculature. We want to make sure that the left side feels equal to the right side. I want to make sure that you can relax the pelvic floor. I want to see if there's any pain, restriction, nerve symptoms, anything like that. And then I get you to contract the pelvic floor. So I'm going to see, can you contract the pelvic floor without using a lot of abdominals, your butt, your adductors or your inner thighs, your toes, your face, your hands. It sounds silly, but I've seen lots of crazy things that people try to do. Yes. I had a gentleman.
We all want to be successful, so we'll find a way.
I had a gentleman years ago that every time I'd get him to contract his pelvic floor, both of his big toes would go up.
Oh, okay.
So then next time when he came to visit me and we were doing some practicing pelvic floor contractions with him sitting, I knew he was contracting his pelvic floor because I could see his big toes go up. So we try to isolate that. I don't want that to happen. So anyways, so we make sure that you can contract the pelvic floor, you can isolate it, you can breathe through that contraction, and then I tell you to relax and make sure that you can relax that pelvic floor,
Okay.
which is just as important.
Mm-hmm.
Do you have any questions about the exam?
No.
If there's pain at any time, we will stop. I will light my pressure or we'll move on to another area.
Okay.
If you want to stop the exam at any time, you just tell me and we're done.
Okay.
Does that sound okay?
I consent.
Okay. And then I offer if they want to go to the bathroom and everyone says yes.
I don't need to go to the bathroom.
Oh, okay. Well, choose the anomaly. So most of the time I'll say, do you want to go pee? And then people are like, yeah. Because by that point we've been talking about pee for 30 minutes, like pee and poop for 30 minutes. So people go, come back, and then we have the exam.
I'm good.
Okay, she doesn't need to. So here we are. Dr. Lamonde is ready for our exam. So I'm just going to go through like we would normally do. Okay? So the first thing that we're going to do is we're going to breathe together. Okay? So I'm going to look at your breathing pattern. You can put your hands wherever you feel comfy. When you breathe in, you're going to breathe in through your nose. You're going to take a really big deep breath. As you breathe out, you're going to breathe out through pursed lips like you're blowing through a straw. Imagine that there's like little birthday candles up on the ceiling and we're trying to blow out those candles. Okay, so it's not like a, I want it to be a long, so we can get all the air up to the ceiling. Okay?
I drank some decaf coffee for you.
Are you ready?
I'm ready.
Okay, nice big inhale. You got a long inhale and then big exhale. I'm just gonna say she does this better than a lot of people do because you're very like self-aware and you do yoga and other things. But what I'm gonna do now, because what I'm looking for your chest to rise, your ribs to come up, your belly to come up, and your ribs to expand back this way. You're also getting some expansion back into your back, but we can't see that obviously here.
Right.
So
I
what?
can feel it.
Yes, but you can feel it into, breathe into your back body. So what I'm going to do now is I'm going to place my hands on your ribs and I'm going to feel if we can feel those ribs kind of move out laterally. So another big inhale. Beautiful. And then big exhale. Lovely. So that's really good. Like I said, that's better than a lot of patients do. So this would be the time that I would normally say, okay, this is great, but we need a little bit more belly, or we need a lot more lateral rib movement. We need some more chest. We need less shoulder elevation, all of those different things. And so sometimes during this exam, I would actually go through some breathing exercises with the patient, because if you're not getting a deep breath, that pressure isn't dispersed down to the pelvic floor, and I can't feel what I need to feel. So even if your pelvic floor is chill and relaxed, if your breath isn't deep enough, that pressure is not going to get down there and I'm not going to feel the movement. So that looked really good though. Good job.
Thanks.
Yeah. And then also I'm going to record a pelvic floor breathing exercise. So we could put the link in there because that's part of the homework that I'm going to give you.
Okay.
So that'll be a separate video. Okay. So now I'm going to take a look at your tummy. I'm going to poke around on your tummy a little bit. I don't want it to be painful. You let me know if there's pain.
Okay.
I'm warning you, my hands are a little cold.
Okay.
Okay. I can always tell when people have been wearing like yoga pants or something because there's always a line on them. All right, so I'm going to go around gently around the abdominal wall. You let me know if there's any pain. Sometimes their tummy starts talking to me during this. We have a little conversation, starts gurgling. Any pain? No? All right, we're going to check that iliacus muscle. Any pain in there?
No.
No?
Maybe the tiniest bit of tenderness, but not bad.
Okay, good. How about that side?
Maybe a teeny bit more than the other side.
But not bad?
Not bad.
Okay. We're going to poke in and around up in your diaphragm here. Is there any pain there?
No.
This is right where the tummy is. No?
No.
Okay, good. I'm going to pull up a little bit here. Any pain there? Or feelings of urgency or any urinary symptoms?
No, just like pressure.
Okay. That's usually an area that brings on symptoms for patients that have had a C-section.
Okay.
Because it pulls right on their C-section scar. And you've not?
But I had an abdominal hysterectomy recently.
Yes. Yes.
But I've worked really hard on my scar tissue.
Yes. She's not a typical patient. Yeah.
But it does show you that if you work on them and you do what she says, you'll get better.
Yes, very true. So sometimes when we pull up on this area, people will say, oh my gosh, that makes me feel like I need to pee. And I'm not pulling up and pushing down on the bladder. Your bladder's actually way down here.
Right.
But if I
Just
pull
pushing up on the fascia.
Yeah. And sometimes that'll pull strongly on the fascia that goes over the bladder, and people go, oh my gosh, I feel like I'm gonna pee right here, or I feel a really strong urge to pee.
Okay.
So what that tells me is that I need to give you homework for that. I don't for you, because you already do all that stuff.
I do that.
Yes.
Every Friday.
Yes. Good. All right, any questions so far?
No.
No. Okay, so here's what we're gonna do for the exam. This pillow is for your knees over on this knee over on the wall. Okay. You're gonna put your feet together.
Okay.
I get real comfy, cozy.
The bottom of my feet or the side of my feet?
Whatever's most comfortable. Okay. So I get really comfy, cozy with my patients because I don't use stirrups, and so I want them to be able to completely relax their legs. So what we're gonna do, we'll bring the sheet up, and I'll give you my little spiel about legs.
Okay.
So, no one is perfectly relaxed during a pelvic exam.
That would be hard.
That just is the way that it is. But if we get a lot of contraction of like the inner thighs or your glutes, your pelvic floor will also co-contract.
Okay.
So what you might feel during the exam is me kind of jiggle your leg a little bit, and that's often because I can feel you contracting and you don't realize that's what you're doing, but over time the leg will start to draw in further and further and further, and then that side of your pelvic floor will start to contract.
Gotcha.
So I'll jiggle your leg and then you'll go, oh, and you'll relax your leg again.
Okay.
Totally natural. Everybody does it.
Okay.
And like I said, if you have any pain at any time, we will stop.
Okay.
We use gloves, latex free.
Nobody wants a latex allergy in their vagina.
Oh my gosh, yeah. Another place that I worked at, a large hospital, not all their gloves were latex free. And so every single time, it'd be like right before the exam, and I'd be like, do you have a latex allergy? Because like most of the gloves were not latex free. We had to go get the special latex free gloves.
Oh.
Yeah, that's not the way it should be.
No,
this is much better. Yeah, much better.
Yeah.
Okay, so here's another little explanation. It totally depends what your symptoms are. If you were coming to me and telling me that you have a lot of pain with sex, difficulty inserting tampons or menstrual cups, difficulty getting gynecological exams, we would change the exam a bit. I would spend a lot more time on the external structures, okay, because the internal exam would be much more uncomfortable, most likely. So I wouldn't be able to get as much information there. But for you, because we're looking for prolapse stuff, if there is anything there that we need to address, and mostly strength and coordination, we won't spend as much time on the external structures. So that's generally what I do. I take a look at the perineal region. I say, okay, is there anything that's jumping out at us? Not literally, but something that's that I need to look at and say, okay, this is something we should address. You can tell a lot from just observation of the perineal area. And that's what we do sometimes with patients that are not comfortable with an internal exam, or they're not able to do an internal exam because of pain. Yeah, right. Or they're very newly postpartum, like a couple days postpartum. I've seen patients and I won't do an internal exam on them.
Right.
Or if they have an active urinary tract infection, I don't do that either.
Okay.
Okay. All right. So what you'll feel now is my finger cold from the lubricant, also cold because my hands are cold. And then you'll feel my other hand, okay? My other hand is just used to spread the tissue a little bit so that we can insert the finger, okay? Let me know at any time if you have discomfort. My hands are cold, I'm sorry. Okay, any pain?
No.
Okay, keep relaxing this leg. Okay, first thing I'm gonna have you do is I'm gonna have you take a deep breath like we just practiced. What I'm feeling for is when you take that full, big deep breath, that the pelvic floor actually comes down and opens up a little bit. Okay, go ahead, big deep breath. Oh, that's great. And then exhale. This is also not typical. So you're getting like really good movement, but it's because you're also a good breather. So what I want to see now is, can you feel that movement? It's hard because my hand is there, but I want to see if you can tap into that kind of feeling.
I can feel it, but let's see if I can feel it.
It's different when you don't have pressure up against the perineum. So big deep breath.
Yes.
Perfect. Do you feel it?
It's subtle.
It's very subtle. That's what I tell everybody. It's subtle. You're not feeling like a woo, like a big opening and then a closure. It's not like that. Okay. It is a subtle kind of breathing of your pelvic floor. So it feels totally normal, and that's great. I can feel it kind of in the front and the back. Okay. So I'm going to gently go around now, kind of like a little clock with gentle pressure. I don't put more pressure than this. Okay. Sometimes it can feel like a lot more pressure because the tissue is sensitive. Okay. But I'm going to do that. I'm going to go around like a clock. You let me know if there's pain, discomfort, or it gives you symptoms like you feel like you have to pee, or you have to poop, or any of that. Okay? Keep relaxing this leg. Sorry. You didn't even realize you were doing it. Yeah. Okay. Any pain, discomfort?
No.
Okay. Any pain, discomfort? No.
No. Nope.
We're up near the bladder now. Any pain, discomfort? Sometimes it makes people feel like they gotta pee because I'm literally next to your bladder. No? All right, I'm right next to your urethra now. No? Okay, other side of the urethra?
No.
No. Okay, up the bladder neck again?
No.
Pain? No?
No pain.
Pressure's normal, but pain's not normal.
No pain.
Okay. All right,
it does feel different than the other areas.
Okay. It feels, actually this side feels a bit tighter than this side does. Any pain there?
No.
Any pain there?
No.
Okay, so now we're gonna do that clock again, but we're gonna go a little bit deeper.
Okay.
You let me know when this was the side that you get that pain in your butt?
This is the butt pain?
Yeah, that's the
the
lateral cutaneous pain.
The intestine pain and the lateral cutaneous nerve.
Okay, so we're gonna do this side first.
Okay.
You let me know if there's any pain with this deeper palpation.
No, just pressure.
Okay.
Okay. Pressure. It takes on a tiny bit of a slightly sharper quality, but it's not painful.
Okay. We'll see if when you contract, if that makes it do it.
Okay. No.
No. It's noticeably tighter on that side.
No, it's no pain.
Okay. Good. So what I'm going to have you do now, we'll start back over here. I want you to contract like you're stopping your urine and your gas at the same time. Okay. And this is, we were talking about like the cues that I give people. That's the number one cue that I give people, but I've got a whole list of cues that I give people if that one doesn't work for you.
Okay.
So go ahead and contract like you're stopping your pee and your gas. Good. Relax. Contract again and hold it.
I think I can't hold it very well.
Relax. Contract again and hold it again. Keep breathing though. It's so hard, isn't it?
Yes.
Yeah. Good. Relax. Okay. So you feel that like woo woo woo, yes. Like you're trying to hold that contraction.
That, like I can get a contraction. I don't know if it's very strong. I can't maintain it.
Yeah. So the strength is okay. Like we grade it like we do any other muscle. So I would give it like a 3. Right now.
It's pretty weak.
Yes, it's not as strong as I would like it to be, but a lot of my patients, especially like newly postpartum in the first 6 months postpartum, their average is like a 1.
Like a twitch.
Yeah, it's like a little flick, and then it immediately lets go. So 3 is not a bad starting point. Okay. I rarely have a patient that like comes in with like a 4+, and they can just sit there and hold it all day, and then they can relax it.
Probably.
Their problem is usually like
the opposite.
Yes, and I tell them to let go, and they're like, okay, and then my finger has lost
trapped.
circulation. Yeah, and that does happen. Keep relaxing this leg.
I think if I put my feet together, it's better.
There you go, that's fine. And that leg's usually more relaxed because it's up against a wall. Okay, so what I'm gonna have you do now is you're gonna couple your breathing with the contraction, and we're gonna see how much stronger it is. Okay? So big inhale, everything relaxes, just like we practiced, but as you exhale, you're gonna contract the pelvic floor the whole time you're exhaling. Okay? So big inhale. Beautiful. Exhale, squeeze, 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 squeeze. Keep squeezing, keep squeezing. Good, 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 good. Keep going, keep going, keep going, keep going. Good, and then let it go. Do you feel how much stronger that contraction felt? It felt way stronger to me. So that, and 99% of the time patients are like, whoa, that felt way stronger.
Yeah. And I felt like I could sustain it.
Hold it for longer.
Yeah.
That's because naturally your pelvic floor wants to rise while you're exhaling. So we're just giving it like that little extra boost. The goal is to be able to dissociate the breathing from your pelvic floor contractions, but this is a starting point for most people. Okay? So we're gonna check this other side. I'm gonna have you do the same thing. Not with the breathing, I just want you to contract like you're stopping your pee and your gas at the same time. Hold it, don't hold your breath. She's concentrating so hard.
Oh, I'm getting my butt cheek on that side.
Uh-huh. Oh, there you go, get it again.
Can't maintain it.
I know, and then let it go. So what happens is that you contract it, you get it up to that 3, and then after a few seconds it goes down. I mean, you lose at least probably 75% of your force.
Yes.
Then you can go, okay, I'm gonna get it again. So you grab it again and it goes back up again. Yes, exactly. So there's a bit of a strength issue, but a lot of it's an endurance thing. Imagine now if I were to get you up and you were to do some dynamic activity and trying to hold that contraction, it would be infinitely harder.
Right.
So if it's difficult in this position, it's definitely more difficult when you're doing heavy lifting or you're jumping or you're whatever.
Right.
So now what I'm gonna have you do is I'm gonna have you cough. It doesn't have to be a huge cough, just a little cough. Good. And so what we should feel is a contraction of the pelvic floor, like a split second before the cough comes, because the brain is cool and it talks to our muscles. So you have that like little reflexive contraction, which is great. And it's probably why you don't get a lot of that stress incontinence when you're coughing or you're sneezing or whatever, unless your bladder's full. So that's good. People lose that, and I have to reteach that to them. I don't reteach a reflex. I can't reteach that, but I can teach like a motor pattern that we do. So what I'm gonna have you do now, I'm gonna have you bear down. People have a really difficult time with this. This is harder for people than contracting the pelvic floor. It won't be hard for you because you're very like aware of your body and how to control your body. But what I'm gonna have you do is push down. What I'm feeling for, this is not the gold standard of what we would do for prolapse testing, but this is initially kind of what I do for patients that say they might have a prolapse or they might feel some mild prolapse symptoms. So I'm gonna have you bear down like you're trying to push my finger out. Good. And then relax. And again. And then relax. And so what I feel is I feel a translation of the urethra a bit and a little bit of the bladder neck. It's not severe. I would categorize it as like mild to mild moderate.
Okay.
If patients are symptomatic with their prolapse, I will also test them in standing because things change.
I do. It does vary.
Okay.
Day to day.
Okay.
Sometimes I do feel it.
You do feel it?
Mm-hmm.
And we didn't talk about that during your history.
Sorry. I
Okay.
did mention that I was told I have bladder prolapse.
Yes. And what does that feeling feel like to you? Pressure, or you're just aware?
Sometimes it will feel like something is trying to fall out.
Mm-hmm.
That was more prevalent before my hysterectomy.
Okay.
I will still feel it sometimes, but it varies
Okay.
day to day.
Okay. Depending on like if you've pooped, how much you've drank, stress levels, activity
I would
levels.
say maybe stress levels are more correlated than anything else you just described.
Yes. When we're stressed, we bear down a lot more.
Yeah, you're just more tense.
Yes.
I feel like that possibly is, for me, a factor.
Do you feel symptomatic after you go on a long hike?
I haven't noticed.
Okay. Because some people feel better after they exercise.
I would say in general, everything about my life feels better after I exercise.
Yes, of course. So even if you're like, if you were to sit there and actually think about that, you might be like,
I'll
oh,
pay attention
maybe.
next time.
Yeah.
I haven't noticed specifically.
I find that a lot of people, their prolapse is more symptomatic on days that they're more sedentary or they're doing a lot of static standing. So they're just
Which we
standing
do a lot
around.
for our job.
Yes. But at least we get to move around a bit. So I've got some patients that like work in retail and they're just standing in one place all day.
Right.
That's
Like cash
really
register.
hard. Yeah. Versus we get to at least bend up and down and up and
All day
down.
long.
Yes. Yes. Okay. So what I'm going to do now, I'm going to take my finger out, okay? And then you can put your legs straight and then we'll talk about what we need to do for homework.
Okay.
Okay? How was it?
Fine. No problems.
Was it painful?
No,
No.
not at all.
Was it awkward? Not for me.
On a scale of 0 to 10, like a 1.
Oh, good.
Maybe 2.
Well, it's not awkward for me.
Only when I realized you were like chatting with me with your finger inside my vagina. That part's
That's
awkward.
always what makes people feel awkward. Or like someone will tell me a personal anecdote and then we get into like a story about something that's
Your
unrelated.
finger's still in there.
And then like I've had patients be like, I just realized I was telling you jokes and literally your finger's inside my vagina. And I'm like, I wasn't thinking about it, but I understand how that would be awkward for you. You know, I get it, but I don't feel it, but I understand.
So, do you want to talk about our findings?
Yes, please.
Okay, so based on what we found, I like your breathing pattern. I'm not going to mess with that too much at all.
Okay.
Tummy was good. She's already doing lots of fascial blasting stuff, so I don't have to give her any kind of abdominal mobilization work, which I give to a lot of patients. I don't have to do that with you. What we found during the pelvic exam,
I'm weak. I have bad endurance.
she in this instance, yes. So there's some weakness there. We definitely could get a lot stronger. And if we kind of extrapolate that out to what it would be when you're standing or doing like much higher level activity, we need to be a lot stronger. So there's weakness there. There's a lack of endurance that we need to work on. And when you're working on that, coordination will get a bit better as well.
And so this, on a positive note, this is what a lot of people think the pelvic floor
Yes.
treatment should be. But on a negative note, this is not necessarily what everyone is.
Right.
I'm just falling into a very typical.
Yes, and actually from a PT perspective, it's much easier for me to treat someone like you with this presentation.
Okay.
Because you're motivated, I'm just gonna give you some strengthening exercises.
And I'm going to do it.
And you're gonna do
I'm
it.
going to be compliant.
Yes, because really what we're trying to do is we're trying to eliminate your symptoms. When it comes to prolapse, we're not going to take, if we were to give you, a grade 2 prolapse, we're not going to bump that up to a 0. It just isn't physiologically possible. Prolapse, like you said in the video, it does shift throughout the day depending on lots of factors. That's fluid intake, that's if you poop that day, it's activity that you're doing that day, it's stress levels is huge, and then a lot of times people, if they're symptomatic, they'll be symptomatic at the very end of the day because their endurance, right? So
That is definitely true for me.
Yep, and that makes total sense. It's like
At the end of a work day specifically.
because you've been standing a lot, you've been doing a lot of like high pressure things, so like thrusting stuff.
And you're there for your patients, so it's just
Yes.
a lot. You're giving a lot.
Yes. Yes, and depending on how busy you are, like rushing around and all that good stuff. So our goal is to make sure that you're not symptomatic anymore and that we're hoping to prevent you from getting a higher grade prolapse.
A more progressed.
Yes.
Okay. I'd like that.
Yes, so a lot of prolapse patients come in and say like, I just want it to go away. Well, I think
You want the symptoms to go away.
yes, and so that's how we manage expectations. I want you, my main goal for a lot of my women is so that I don't want you to have to think about your vagina
Good.
or like your pelvic
Well,
floor
and here's the thing.
on a daily basis.
If you don't feel if you don't feel symptoms, it doesn't exist in your world.
Right.
Like a woman with a prolapse that has no symptoms doesn't know she necessarily has it.
No, and I've seen that a lot. People come in for like a urinary symptom and I'm telling them like, oh, by the way, did you know that you also have a grade 2 plus 2.5, however you want to say, prolapse? And they'll be like, oh no, you know, but because they don't feel it symptomatically. And so it's all just kind of based on like what your symptoms are, what you want to address, and helping you to remain strong throughout the rest of your life. So we're going to work on strengthening for you in various positions.
Okay.
The one we start off with is in the most relaxed position, which is laying down.
Mm-hmm.
You can either lay on your back. This is a separate video, so I'm going to do a separate video for a breathing exercise. This is one of the most basic exercises that I give people.
So we'll do maybe a little link.
Like a little link, and you can kind of watch that.
Maybe a link here and here.
Mm-hmm. So it's a breathing exercise that I talk to people about doing this, like balloon breathing, full breathing, 360 breathing. There's all kinds of words for it. And then we're going to add a pelvic floor contraction in with the exhale, like we did in the exam.
Okay, so am I basically repeating what you used as an assessment tool?
Exactly.
Okay.
So you're going to do these big exhales. You're contracting the pelvic floor throughout your entire exhale, and then you'll completely
I
let
have
it go.
long exhales too.
Your breathing is so good.
Big breaths.
It's so good.
My endurance is going to be way better.
You'd be.
And are you going to retest this?
Yes.
Oh, okay.
And then we use that. This is also a coordination thing. So you know what it feels like to inhale and relax, exhale and contract. Because later on down the road, when I say, hey, I'd like you to do a squat, or we're doing a weighted squat, and I want to do the breathing with the pelvic floor contraction, you don't have to think about it so hard because you've already practiced that and your body already knows what to do.
Okay.
So that's what we're going to work on.
Generally speaking, if a patient is motivated and compliant, I know we're not supposed to use that word anymore, if they do their homework, how long would it be before you would start to see some improvement in symptoms, as a general rule?
Totally depends on the diagnosis.
In my diagnosis.
Yes, in your diagnosis.
And I have high levels of body awareness.
Yes.
So let's assume the patient is motivated.
Mm-hmm.
They're going to do what you give them instruction for. And in my case, I have pretty high levels of body awareness. That's always a big factor. Body awareness is a big thing.
Mm-hmm.
So in this circumstance, so if I start doing my exercises, which I will,
Mm-hmm.
generally, how long would it take before, like a range, before I start to be like, oh, I think that's maybe a bit better?
With my symptomatic prolapse patients, when we change a few little things, people can see like improvement in symptoms very quickly. I mean, like within a couple of days.
Okay.
But because prolapse is a moving target, and it's
Some days may be better than others.
Some days may be better than others. I tell people it's very much like a roller coaster when it comes
We're
to
looking for
prolapse
an
right now.
overall improvement. Less
Yes.
frequency, intensity, duration of symptoms.
Exactly. So to set expectations for you, I'd say, hey, I want to see you every 2 to 4 weeks, because you don't really need a lot of like hands-on anything. You're already very self-aware. And then I might see you for like a total period of maybe 3 months.
So
Because I'm only seeing
maybe
you.
a couple more appointments.
Yeah.
Okay.
Yeah. And the thing with
So
prolapse,
maybe there'll be another video. Maybe there'll be a video number 6 after like 3 months.
and with prolapse, it's important for you to start thinking about where your symptoms come from. So
Okay.
just being a little bit more aware, like, hey, it's actually when I'm really stressed, because guess what we talk about then?
Stress management.
Stress management. Or it's when I'm wearing a really heavy pack when I'm hiking. So then then I go, okay, I'd like to see what you look like with your pack on.
So I bring it in.
Yes, and
Okay.
I'd like to watch you walk with your pack, and I'd like to see how you're breathing with your pack.
Okay.
Um,
Then you're gonna have to come with me on a hike though, because it's uphill.
and that's okay. So we can do that. That's the nice thing about our practice, that we can do stuff like that.
Let's go
So
hike.
yeah. Or you start to realize it's at certain times of the month, because you're still having kind of these like hormonal
And that
shifts.
is such a tricky thing, because I know that that's happening, and there's very subtle cues of that,
Mhm.
mostly breast tenderness.
Right.
And like just feeling kind of chubby.
Or like also feeling a little bit angry.
Yeah, like
sometimes.
everybody's annoying you.
Yeah.
But in terms of like the typical symptom, I don't have that anymore. So I am not aware of kind of what that wave looks like, where I used to be aware.
Yeah.
There was much more obvious symptoms.
So I've got some patients who are with prolapse or with their incontinence, they're only symptomatic around ovulation. So I just talk to them about like, we're doing the exercises, we're getting stronger, we're changing some of the mechanics that might be increasing their symptoms, but really it might be Or are you lowering?
I'm trying to bring you closer to me. Yeah.
Really, it might be that we change our workouts during that period of time.
Oh, that could be a whole
That's a whole
other
other
video. Women and periodization and training. Oh, it's fascinating subject matter.
It is.
And it is a really neglected, albeit more researched area than in the last few years. Fascinating stuff. You and I have both tracked that a little bit before my hysterectomy. It was easier to do that, about how you feel, how you recover, your strength, etc. during the different phases of your menstrual cycle.
Yeah, there's
fascinating stuff. Love it.
There's we should do a whole nother video on that. But
we really should.
There's a whole psychology behind that too, of being okay with resting at certain times because your body is wanting you to chill out a little bit.
The tricky thing is when you're an athlete and when you're expected to perform at your best is not able to accommodate that.
Right.
So sometimes in female athletics, the people that perform well on any given day just might be in the ideal phase of their cycle, and other people just might not be in the ideal phase of their cycle.
It's very true.
And
I know it myself.
Men don't have that.
Right.
Male athletes don't have that additional variable to deal with. That is a really interesting branch of research. And if you also look at most athlete research over the years, it has been almost exclusively, not exclusively now, but almost exclusively done on males. So that is not you can't extrapolate that to a female population well. I don't know how we just got on that subject.
Yeah. But I talk to patients about that because I want them to know where their symptoms are coming from. I want them to be aware. I have a lot of patients that come back and see me 2 visits later and they're like, I'm only symptomatic at these times.
Right.
And if they hadn't come to see me, they wouldn't know that.
Well, and also sometimes just knowing that, you're like, okay, I'm about to ovulate. I have a little bit more symptoms. I can work with this now, as opposed to when you don't know that, it's very frustrating.
Yeah. And I will just take like a little quote from Sarah Duvall, who I did one of my certifications through. She says, just like a lot of pelvic therapists know, that prolapse in particular is very difficult to rehab because it is a moving target and it gets better and you're more symptomatic, less, and blah, blah, blah. But she wants you to get to the point where maybe you're okay with it, but one step beyond that is to be almost grateful for your prolapse. And I'll say why is because sometimes if we're paying attention to those symptoms, that's the only way we know that we're not managing our stress well, or not managing our bowel habits well, or we're not sleeping enough.
So you can think of it as an indicator for a larger issue.
Yes. And so I've had patients that have told me that. They're like, actually, I know when I feel symptomatic, then I'm pushing myself too hard and I'm burning out. I'm too stressed. I'm not pooping well. I'm not peeing well, like all of these things. And it gets to the point where like, hey, that's kind of a cool, if you shift your thought process, it's kind of a cool way, a barometer of our health.
I like that. I like that a lot, actually, because that's just reframing something. It kind of, another thing that I use with my patient population is I deal with a lot of chronic pain, and I know that you do as well in this arena and others, but that's a patient population that not everyone is super excited to work with because there's so many factors involved. And I often tell people, if you are open to the idea that one day you will be able to look back on this journey and you will see the greater purpose in it. So again, a little sidebar here. I had an episode of chronic pain for about 3 years after a surgery in my knee that didn't go to plan. And in hindsight, had that not happened, I wouldn't have gone to do my postdoctoral fellowship in chronic pain. I wouldn't have changed everything about my practice and how I treat patients. I would not have understood how that can impact your life in the same way. And so I'm obviously well and great and no issues now. And I can also use that to help patients to know that there is the potential to be on the other side of this and be totally asymptomatic. Like, this doesn't have to be here forever.
Yes.
And so I think that was the greater purpose in my chronic pain, and hopefully patients can come to a place where they can see that this happened ultimately for a reason if you're willing to receive that information.
And we can get to the point where we see our symptoms as a way that our body's communicating with us versus punishing us.
Right.
So
I like that.
yeah, so like, oh hey, maybe I need to chill out and I need to, spend more time with friends and family and not kill myself in the gym for the next couple of days.
Well, and we might need to make another video in general about stress management, but as Americans, there is a huge emphasis placed on very specific factors of health, and arguably not even necessarily health, rather vanity.
Mm-hmm.
And so the concept of health is almost completely removed from the picture, where it's, are you thin enough? Are you pretty enough? Are you productive enough? And that makes you a valuable human. And in the process of that, they lose contact with the things that they value. They lose contact with their actual health and wellness, and they engage in unhealthy behaviors because they want a result regardless of how it may destroy their bodies.
Really rigid ideology too about certain things.
And so it's a tricky place to be in modern culture, and we're also so fortunate that most people have the resources to manipulate their environment like that, whereas if you grew or lived in a place where those options were unavailable to you, you might not have anxiety, you might not have an eating disorder, you might not have, panic and distress and depression, because those options aren't available to you. Because you're just trying to survive. So
just trying to live.
Yeah, you're just trying to figure out where your next meal might come from. And so, and as someone who works, I've spent a great deal of time in a very, very poor nation. I don't see the same pathologies in that country. Haiti is where I go, that I see in the U.S. at all.
Yeah.
And I actually wrote part of my fellowship. I actually wrote a paper on the experience of pain differences that I noted between Haitians and Americans. It's a very interesting subject matter. We're getting off on some tangents. We can edit all of this out, but
it is really interesting though.
But this is, stress. I think to tie this all back together, stress is something that in modern culture is a psychological warfare. Whereas hundreds of years ago, there was a physical act that probably had to take place. If a tiger is going to eat you, you were either going to fight it, run from it, or die. So you had a physical exertion, if you will, to relieve the stress of that moment. Whereas now, the emotional stress that people experience gets kind of bottled up in their bodies and presents itself in physical manifestation, whether that's a disease. It could be anything from digestive issues to skin problems to anxiety, depression, cardiovascular disease, and so on. So all of these things that present themselves. And if we as a culture could start to tap into that, of like, my body's trying to tell me something if I have the ears, eyes to listen. And hopefully we help people develop the tools to be able to do that. And even someone like myself, who is very aware of those things, I maybe didn't recognize that perhaps my prolapse symptoms increase in times of increased stress. And I feel like, in general, I feel like I manage my stress well, but when I don't, things internally occur. I'm not someone that's going to externally radiate my stress, so maybe that's one of my symptoms. And I can use that as a tool moving forward.
Yes.
Cool. My bladder is telling me to calm down.
Yes. I think it's a cool way to look at it. I think it's and managing expectations and changing that view towards symptoms, that it doesn't mean you're messing up and that you're doing something wrong.
Yeah, that you're being punished.
That you're being punished for something. It just means that this is an opportunity for us to use it to see what else in your environment can we make.
Or your response to the environment.
Or your response to the environment.
That whole concept of your circle of control, your circle of influence, your circle of concern. People spend a lot of time in that circle of concern. We need to spend more time in the circle of control.
Yeah. And that's, so now you really can't.
Little plug for 7 Habits of Highly Effective People there.
You can't be surprised now when your PT starts talking to you about how you manage your stress, what your social life is like. What
are your interpersonal relationships like?
What do you do for fun? I ask all my patients that. And they
You did not ask me what I do for fun.
I'm sorry, I already know what you do for fun, and that's
you
probably...
You do know what I do for fun.
So...
dangerous things.
Dangerous things.
Yes, things that require a bit of adrenaline.
Type 2 fun.
I love type 2 fun.
Yeah, hiking.
I even like type 2.5 fun.
You probably like a little bit of type 3 fun.
I probably do.
Yeah. I'm like a type 1 to 1.5 fun. Sometimes type 2 if I'm convinced, but.
God, I love type 2 fun.
Nah.
Yeah, I do. I always have.
Go do another video on types of fun.
We should. That's another video. We got so
we
many
can have
ideas.
Nathan in that video.
Oh yeah, we could definitely have Nathan in that video if he
Mhm.
talks loud enough for you to hear.
We'll mic him.
Yeah, we'll put a mic on Nathan and I won't need one.
Yeah. Won't either. Yeah. So yeah. So there you go.
Thank you.
You're welcome.
What are my exercises?
I'm gonna give you a breathing exercise.
Okay, the one that
we're gonna do, the link to, and then I'm also that's the start, because I find that is difficult for people to wrap their head around and to get that into their habit. So I have them do it in the morning when they wake up.
Ah, good. I was gonna say patients want specifics.
Yeah, in the morning when you wake up, after you go pee, because I don't
Okay.
want you doing it with a full bladder. It
Okay.
just is distracting. You can do it laying on the floor, you can do it in the bed, whatever. And then at night as you're going to sleep, because it already gets you in a mindset of like, okay, now we're deep breathing.
Oh yeah, you're kind of killing two birds with one stone.
Exactly right.
Okay. And is there a certain number? Am I looking for a level of fatigue? Like, how do I determine?
So for you, because you're able to fully relax in between each contraction, you're gonna do it, you'll do a couple minutes of just breathing. So that's just you deep breathing. There's no pelvic floor stuff. I just want you thinking about what's going on down there.
Okay, so breathing without the pelvic floor.
That's right.
Got it.
Then you're gonna add like 2 to 4 minutes, depending on what you're in.
Whoa.
Yeah, of contraction
She's
with
not being unreasonable. She's asking for like 4 to 5 minutes of exercise total.
total. And you might be like, oh, 2 minutes, that's fine.
Does this count toward my 20 minutes of daily exercise?
It does.
Oh,
I will
okay.
give you credit for that.
Okay.
And for 2 minutes, contracting every time you exhale, you will be tired.
Yeah.
Yeah, you will be very tired. It doesn't seem like someone who hasn't gone through this would be like, oh, that's nothing.
And for someone like myself, I would consider myself reasonably athletic. If I can go hiking for days, 10 hours a day.
This is a
But
different
This
ballgame.
2 minutes is probably going to be harder.
And it's also mentally exhausting.
Well, for me, part of it is because this is a multifaceted act. This is really an act of meditation as well. And for someone like me, where my mind is difficult to turn off, it will be very good for my sleep, I feel, sure. And I do something like this already, just not with the concentration on my pelvic floor. But I also think that it will force me to recognize and like stop, which is going to be hard for me.
Yes.
Good for me though.
Yes.
And again, I like doing hard things.
If you get to the point where you're feeling like it starts to spasm or you're getting really fatigued, you just stop. Call it a day.
Like if it's like,
Yeah.
or I'm starting to get like cramping okay.
Or you start to notice that your pelvic floor has given up and now your glutes want to take over.
Okay. When we were doing it earlier, my left one wanted to participate, but not my right one. I noticed that. We'll see if that is consistent. It might also...
That left side was tighter too. The tone was higher on that side.
Interesting. I guess we'll see if that changes. So when shall I return to see you?
So generally I like to see people, yes, it depends. But for someone...
That's always the right answer.
It depends. Generally I'll see people 1 week after they've seen me for the first time because most people are doing their homework incorrectly.
You need to correct.
Yes.
And reteach, yeah.
Even though I send my patients can confirm this, I send a very detailed email to them to tell them exactly what to do, but it's still, I understand.
We send videos of
And we send
exercises.
videos. I understand it still gets confusing and it's a lot to take in. So usually 1 to 2 weeks after the initial visit, and then I might not see you again for like 3 weeks after that.
Okay. Well, I will do my exercises. I will be a motivated patient. I am a motivated patient always. And
here's the other thing, you're quite simple because you're not dealing with urinary stuff and you're not dealing with bowel stuff. You're not dealing with pain stuff. You are, but that's other areas that we can address also when you come back in a week.
so in a week or two, we'll examine.
We can look at that.
So this series might have a few more
stuff.
a few
Yeah.
more videos. That's okay. That's okay.
But then also the second piece of homework is for you to start thinking about your symptoms and when those are occurring. And so you can keep that in your phone as like a little note, and you might be like, oh, put the date in, I'm symptomatic, what was happening
And are
that
you
day?
talking about whether I have
Prolapse or pain or like nerve pain?
this stuff? Okay.
Or even
Or
like
my butt? Any of those?
or low back stuff is worse.
Okay. And so are you looking for me to tell you maybe the time of day, or if I felt like stress was involved, or if I was doing a physical activity.
Stress and physical activity.
Stress and physical activity. Okay. I'll put it in my little reminders.
Yes.
That's how I'll keep track. And then I guess I'll show it to you when I come back.
It doesn't seem like a lot of homework, but you'd be surprised. I mean, a lot of people have difficulty adding that into their life. I know you are diligent, but it is difficult for people.
Well, and part of what we're doing right now with this whole 30-day trial of things is let's say this is something that needed to be part of my life on a long-term basis. I call it making something sticky.
Mm-hmm.
To make something sticky, you have to partner it with something that's already sticky. So for what you've done is you've told me to do it in the morning after I've gone to the bathroom. That one probably will be harder than the evening. The
morning's always harder.
The evening's going to be easier because I'm already lying down and going to bed. I wonder if I'll fall asleep.
I've had some people do it while they'll sit in a recliner while they're drinking their morning coffee. That's fine too.
And you want me to do it supine, or you want me to do it in various positions?
We'll start in supine.
Okay.
We'll start there, or you can do it in side lying. But you're going to be horizontal.
Horizontal
Mm-hmm.
for the first couple weeks.
Mm-hmm.
Okay.
Yes.
We'll let you know if I get better. If I have
Yes.
better strength, better endurance, and less symptoms.
Yes.
Okay. Thanks.
Ta-da!